data to be private necessarily. What they want is the option of privacy. So they want to be able to control how private their data is. And if you give them the choice, and that's a statistic for MedHealth, we have millions of trackers that have been created in MedHealth with hundreds of millions of data points, and 85% of users choose to make their data public. 85% of people, when asked a question, do you want to make this data private or public, they say, I want to make it public. Now, there are certain kinds of data that they choose to hide, certain kinds of data they don't want to expose for for a various set of reasons. But the overall statistic is 85% want it public. And the reason is, as Chris alluded, that they see a benefit of making it public. You know, when I put it out there, other people look at it, they give me feedback, I can compare my data to others, etc. So the perception of risk is much lower than the government is trying to convince us that it is, but that doesn't mean that people shouldn't have the right for privacy, and in some cases they want to always feel secure that they have the ability to do that. And I think that's the key, is differentiating between do we expose everything and make it available to everyone, anyone can have access to it, or do we give people the key to their data and allowing them to own it and to make that decision themselves?
Great. Good. So we've got three questions. We've got one here in the back, we've got one over here, and over here. Oh. We've got one here, and we've got one here. So great, you can move that around. The first one was here in the back. We'll just repeat it. Go ahead.
The big question for me has always been, where would you house the centralized database, and who would you put in charge of it? Would you put the government in charge of it? One of you guys in charge of it?
Definitely not the government.
Be responsible for
Let me just repeat the question. Okay, do you mind if I repeat it? Okay, so the question was, for those in the back, so who should be in charge of this? The government, I'm going to try to say that without laughing. The government, some individual company, or the patient. And so I think those are the choices given, although I think you would be glad if you want to select from any of them. Everybody heard the question okay? All right.
Let the patient choose. Let the patient choose, right, where they want to put their data. Let's build companies that patients trust and let them put the data in. Right? I mean, what's the alternative? We're going to let the doctors decide?
Controller. He's already controlling the data today.
The physician?
Yeah.
No. The patient has to control the data.
What?
Because it's their data.
It's their data.
They need to be able to do what they need, what they want to do.
Physicians haven't proven that they can do. But why would physicians be the gatekeeper to my data? Why would a physician decide who to share my data with? I'm not saying they don't have rights to my data and they can't share some of my data, but to them having rights to my keys without me having the keys too? No way. No, I just don't think that's a viable end result. Right?
And I would definitely trust it to a company that has a good track record, like a Practice Fusion. I mean, their business depends on my data being secure, like their whole existence. And if they mess it up, it's gone, their whole business. So for me, that gives me a level of trust.
Did you want to ask a follow-up? Because this is what we want. I mean, this is the kind of conversation I want to have, which is, this is what happens in the coffee shop among us, so let's keep going. This is what's interesting to people. Let's go on.
It's got to be centralized. It's got to be somewhere in the cloud somewhere. Whether it's the government who's going to own it, or it's you who's going to own it, somebody's got to own it. And it's not going to be the patient. The patient just needs to be able to access it, and we can't be truly interoperable. We can't be truly, we can't access from any point in the world, whether it's a military battlefield, or it's somewhere in Miami with your vacation, or it's wherever you are. You need to be able to access it from one system or multiple systems.
So let me just repeat it, so everybody back can hear it. So the question was, or the proposition I think was that patients can't own it, was that it probably has to be centralized, and who should that be and what that be. It couldn't actually work that way. One question I'd like to ask you to clarify, because I think sometimes these words, it's like, we all work in healthcare. Yeah, there's like 97,000 different things, right? So let's get a little bit more specific. When you say, I'll ask each of you to answer this when you answer the question, and if I answer the question, I'll do the same. Ownership. Okay, so we're getting stuck up on ownership, and I'm not sure that you're not talking about location. And I want to make sure that we're talking about, we're using the same terminology. So are you talking about location or ownership or access? Because I think between you and Derek and one of the other answers, we might be talking about three different things here.
Responsibility for the security of the data.
Okay, did everybody hear that? His answer was responsibility for security of the data. Okay, please, I know you want to say something.
Sure. The first, I want to make a couple of points. The first one is, if you centralizing things is making them less secure, right? So if you want to store all the money that you have, you don't want to put all the community's money in one location, because that means someone can break in there and take all the money at once. And the same thing happens. There is no system that's infinitely secure. There's always going to be a way to get to the data, and if you assume that all the data is going to be stored in a central location, that makes it infinitely less secure, because that means you need to break one system, a single point of failure, and then you lose all the data. So in a way, the distribution is actually security. So having your data in so many places means if any one part is compromised, the whole site doesn't lose all its data. So that's the first point I want to make. The second point is that, and I'm kind of repeating, the user has to own their data. It has to be your own decision. I think I have a tremendous respect to doctors. My father's a doctor, and we work with them every day, and we think that they're a major part of the solution. When a lot of people are trying to push them out and say, no, you're not part of the solution, we think they're part of the solution. They're kind of the pilots of a plane when it comes to healthcare. But with all respect, I don't think they own the data. Your doctor owning your data is equivalent of your investment manager owning your bank account. It doesn't make sense, because they're going to help you, they're going to advise you, they're going to treat you, but at the end of the day, it's your data yourself, in the same way that money is yours.
I would even go so far as to say we should take the word ownership out of the equation completely. I mean, it's a provider-entered data. We know patient-entered data doesn't work, like Google Health gone. So provider-entered, patient-accessible, and portable, so the patient has control over who has access to it and who needs to be able to access their information to care for them. And they also have control over who else can see it in their care network, in their social network perhaps, if they're trying to get better or lose weight. You know, multiple studies show that the more people that are involved in your weight loss, the more likely you are to lose. So unlocking that data with the patient authorizing that's really critical. But nobody really, I mean, it's data about you, but you don't really own it. I mean, it's a weird concept, I guess, but it's not yours to go and grab it and sell it for some sort of value. So we don't use the word ownership at all, because it's physician-entered. Practice Fusion happens to we're essentially custodians for that data, and then patients can have access to share with anybody. Everybody knows the acronym PHR, Personal Health Record. That will be changing over the next few years to be more of a personally controlled health record. So you'll start hearing PCHR a lot.
So before we, there's a couple other questions. I want to make sure everybody gets a chance thanks, Chris. There's a couple other questions I want to make sure everybody gets a chance. I just want to make sure that, do you have any follow-up or anything else you want to add at the minute? You sure? All right. Because I want this to be conversational. This is not, the table is a misnomer. Trust me. So there was another question here, gentleman with the microphone.
Yeah, you're talking about all of the data as if it's the same value. If I get a test for strep throat, I don't care if the whole world knows about it, but if a teenage girl gets a pregnancy test, that's a different quality of data. And so I think that's also important, is the kinds of data. Some really should be secure, private. Others, it doesn't matter. Test for strep throat. I don't care if the whole world knows.
So, with all due respect, I actually want to jump in on one of these. It's really hard for me not to talk. You have no idea how. Bernard's like, do you want to moderate? I'm like, no, I want to talk. So one thing I would say is, I think there might have been a misconception, because as I was hearing this, I don't think any one of these guys was saying, data security doesn't matter, right? I think that, because even in that case, like, I don't know how to judge culturally, internationally, what pieces of data are interesting for other things, right? So your example is poignant and certainly is a good one. I don't know if it transfers to all cultures. I don't know if it transfers to all things. And although we started with U.S. healthcare law and things like that, healthcare is a global issue. And if you're going to build a healthcare company, you're going to build a global healthcare company, at least if you're trying to build something at scale. And so I don't think that I heard that anyone saying it's not important. In fact, I would argue that you're right. In certain cultures, certain pieces of data have more meaning. We have to respect all of them as if they are critical to your daily life. Because I just don't know culturally, and different segments, different religions, and even forget globally for a second. from where we were, I remember we only did English to start. We tried to sell the product in New York. And we're like, you need Chinese, you need Russian, you need we're like, it's New York. It's like California, we didn't know what we were doing. So, so we made, yeah, it was not at all. So I think that's the part. It's even within those cultures, within those areas, especially as we see the culture change. While I agree with your point, I'm not sure that there's not a culture out there where strep throat means you get stoned or whatever. You know, it's just, so I think we have a responsibility for all of that.
Yeah. I mean, so when I said the patient owns the data, obviously they don't have a responsibility for the security of the data. I think the data can be more securely put somewhere else. One of the challenges of that, of the provider owning the data, from my perspective, what I interpreted by that, not necessarily what you meant by it, but what I interpreted by that is one of the biggest challenges is, and this is one of the potential great leverages of a company like Fastest Fusion, if they can get this leverage, this flywheel going, is, it's my data, and you might push out a fantastic, wonderful PHR, and it's my health story. It's about me, right? But one chapter of my story is in that EMR over there, which doesn't talk to anybody else. There's another paragraph that's in this PHR over here, or this EMR over here, and there's another 2 chapters that is over in there, and the rest of it's in Kaiser. And I can't make sense of it at all, right? So the question of having the centralized data source or a publishable data source or subscribable data source, where the patient should have access to it and should have the keys at some level of granularity to control the privacy of that data. It's not up to the physician to decide who sees my data necessarily, right? I should have some control over that. So that was my only point. And the separation of data sources and the lack of data liquidity is a huge problem.
So this gentleman's been waiting patiently, and he's in the cheap seats in the way back.
Yeah,
so.
I can't see. Nobody can see it. I need a mic. There's got to be a long question. So everybody alluded to APIs, so I just wanted to ask you what your thoughts are on the fact that right now there's only 2 ways to get data from organizations today, which is HL7 or EDI transactions, which are absolutely both suck terribly. So I've been looking at this project called HData, which is talking about RESTful APIs for healthcare transaction information. So have you guys actually, one of the barriers to all of this is the fact that none of us can communicate with each other. Every time you talk to a customer, it's always HL7 and there's 9 flavors. And I think it could be a lot easier, and all you need to do is say, give me the discharge data for this individual through a call on an API and get it back, and we would solve about half the problems that these people have been trying to work on for 15 years. So what are your thoughts on that, and how can we get that going? Because I think you can't build a mobile phone app if you don't have the ability to talk to something that's fairly web-friendly and easy, like Facebook and Google.
So I'd like to ask Chris to start with that question, if you don't mind, just because you've been building things off of APIs and stuff. But one thing I do want to just double check on is, were there any other questions? I think it was privacy is one of those issues. I expect people.
Related.
It's definitely related.
Because
I just want to
authentication's a problem.
Absolutely. I'm not skipping your question. I just want to get a quick show of hands where the other questions are. Yeah. Okay. We have back here. Okay, great. So we're going to answer this one, and I just want to make sure I catch everybody and kind of get an idea if we can move the microphones around. Okay. Thank you. Okay, Chris, you want to?
At least from our standpoint, we think a lot less about standards than clinical organizations communicating. To us, it's give us some sort of access, we will figure it out. We will figure out what we need and how to do it. I don't want to wait around for any sort of standard.
I want to clarify the question. It's exactly what I'm saying. As I'm saying, if you go to Facebook Connect, you just make one call on the web, and they tell you how to talk to them. If I go to Google, they give me one call and they talk to them. But you don't have that here. So my question is more specifically, how do we as a non-organizing entity organize ourselves in a way that allows you, Practice Fusion, to publish an API that I understand and move on?
You don't. Practice Fusion will do it themselves. They have the data, they'll develop an API, and we'll use the API and it'll work, and everyone else will follow whoever gets it right and figures it out.
Can I just make one quick point? So I spent 5 years of my life fighting with standards. We built an instant messaging company that had this huge goal of saying there was, I think at that count, about 9 years ago, there was about 26 different instant messaging protocols. And nobody could talk to anyone. It was the most painful problem in the world. And one thing we learned very quickly is that you can't force communication. There has to be a force outside of it that has a use case that can only be solved by people talking to each other to force communication. And today that still doesn't exist. There's in the online health space, there is still not an overuse case that everybody sees as big value in that solves the healthcare problem, or a big part of the healthcare problem, that requires everyone to talk to each other. I think once that happens, the protocols will just solve themselves out.
Kazu's done a really good job of creating this sort of private network of physicians plus data connected across other entities. It cost them $5 billion with a B though, so that's not really reasonable, especially for the 650,000 physicians in the U.S. who are in private practice, haven't seen their salaries increase even with inflation for 20 years. So the price tag is really important, and that's the only reason we've been successful. Making it free was the best decision we ever made. We wouldn't be in business without it. But one of the biggest things plaguing healthcare now, and for the hopefully only a short term in the future, is interoperability. The ability to transmit and transfer your medical record between different platforms is almost non-existent right now, primarily because there's not a lot of impetus to do it. There's no real value to different EMRs speaking with each other. They don't make money off of it. There's actually laws against making money off of it, so they're disincentivized to share that data. With the American Recovery and Reinvestment Act, part of Stage 3 meaningful use. I'll get really wonky here if you let me, but I promise I wouldn't do that. Essentially, there are exchanges being set up to facilitate that communication between EMRs. So it's being sort of thrust upon the vendors to make that happen if they want to be competitive. So that's one way that the government has stepped in and said, look, the market's not going to do this itself. It's not a profitable venture. We're going to mandate that it's done. And ultimately, doctors benefit, patients benefit, and vendors like Practice Fusion that would be out of business without the stimulus bill benefit. And the problem with interoperability not happening yet is because everybody kind of came up with their own little standard. When we've had a standard all along, it's called XML. I mean, developers know how to communicate this way, right? So why hasn't that happened? Well, you're dealing with a lot of big iron client-server vendors that are used to communicating. They built their own TCP/IP in some cases. So it's almost like there's a pride in developing your own standard. Hopefully that will deteriorate as time goes on. We are fully committed to exposing things via SOAP, via XML, via REST, things that the normal everyday developer just has to be able to obtain a token and use that token in their calls to us, and they can access the data, access the pump data through to us as well.
I'm more of a JSON guy than XML guy. That's fine. Yeah. Oh, thank you very much. That's very kind. So there's a question on the microphone over here.
Well, I'm almost jumping out of my seat in a way. I've been dealing with this for a while, and there's a difference between just exchanging data or consuming pieces of data, and actually having what we call, to get wonky, semantic interoperability, actually a meaningful exchange of the information so that it's understood from a semantic perspective, if you will, and you can compute on it and understand what you're doing with it. That's one of the things that's really missing significantly today. And I think even if you did the XML maneuver and the API, it's actually what is the meaning of the data that's coming across. You have to standardize that if you're going to have a platform. I don't think you can have 50 different vendors doing this, and they've all done that, by the way, in healthcare. You've probably seen that, and I think Practice Fusion in particular, when you're having to connect with labs, experience that. Everybody has their own, what they call data dictionary, and you're having to deal with that in some way. And you kind of just imagine if they all use something like Loink, for example. Not that Loink did magic, but...
We force them to conform to our standard.
Exactly. So I think it takes a big vendor to do that.
To do that a year ago.
Yeah. The other thing I was going to mention, hopefully that was enough, I don't know, there was a lot of hubbub about, data versus semantic interoperability. The other thing is, as a physician, one of the things that I haven't seen solved very well yet is this issue that to be able to provide real value, for example, quality reporting and things that I might be able to use to better my practice, I need computable data, but yet I'm producing it as narrative text often. And in fact, we've computerized the medical record. There's a famous book that, I don't know, it's like 20 years old, that talks about the computer-based patient record versus the EMR. And the EMR is basically a paper-based record that you've made digital, electronic. It's not computable, really. And the computer-based patient record is you have discrete data elements that you're capturing that can drive a process. And the thing is, capturing that from a physician is actually hard for the physician to do. I haven't seen the magic, the secret sauce to be able to do it. You know, I've seen Epic. I mean, we use Epic, and I know. Thank you. Trust me, we started a free clinic, and we got Practice Fusion, and I have to thank you very much for that.
Awesome.
It's been an awesome experience, and it was actually it was extremely painless compared to what we did in the hospital with Epic.
$5 billion.
But don't repeat that to my CIO, by the way.
That's me in 2014.
But the idea of the smart phrase and things like that, we've tried to deal with it, but it's a big struggle to try to get it as a granular enough to make it computable, yet make it user-friendly enough to be usable so that I don't spend 6 hours trying to document something that took me 15 minutes on a piece of paper.
Yeah, the long structured versus unstructured data question, nobody's done it really well. It's something we don't do extremely well right now. I mean, we're capturing diagnostic and allergy and medication, immunization, all that information does come in. Vital signs, of course, is very structured, but when it comes to soap encounters and non-structured data, it gets much more challenging. There's a standard emerging called SNOMED CT that is supposed to be this giant savior of turning unstructured into structured, but it'll all come down to implementation. Those template lines that you pull over as you're creating your chart node, those can be tagged with SNOMED, and that's one way that we get there. There are tons of companies out there promising to parse through and cull your encounter node to extract structured information, but that's going to be wrought with all kinds of error. But at least it's being captured in a digital format so it can be crawled if you want to, as opposed to trying to translate doctor handwriting from a piece of paper into some sort of analytical engine. Honestly, if it were an easy problem, it would have been solved already.
So you've been waiting in the back there patiently for the very beginning, so if we could get him the mic, thank you.
So is the real tipping point that we're talking about not necessarily at the healthcare consumer patient level, but at the provider level? And everyone at this table probably has a lot more experience than anybody in this room, but what's the heterogeneity like in the healthcare provider space and their understanding of HIPAA compliance, security of data and information, and how they need to handle it? And until they get on board, I think, and they can convince the healthcare consumers that they've got it, I think it's going to be very difficult. I can give you a personal experience for myself. When my healthcare provider moved on to an electronic health record, there was a mistake made in one of the fields that was actually picked up by my insurer. And they picked that up, and all of a sudden the only reason I knew it happened is because the premium suddenly went through the roof. Luckily I have a great healthcare provider, and immediately within 12 hours she fought back and made sure that the mistake was picked up and the payers actually understood that that was their error and got everything reversed. But that's another danger of actually not having control of your own healthcare data, not being a participant in where that data goes. But the point again, going back again, is I think there's another level here that's got to convince the rest of us as consumers that they've got it before we jump on board.
But had it been locked away in paper, you never would have found that error, right?
That's correct. Yeah. But it was a transition to supposedly a better system that got me in worse trouble than I was at.
Fair enough, but it's a stepwise. We're kind of going through stepwise changes.
Right, but that's the minor point. The bigger point here is the heterogeneity amongst what do we believe healthcare providers are capable of and understanding of what they need to do to keep our data secure.
I think the consumer plays a huge role over here, meaning the consumer is going to be the one who, or the patient is the one who's going to push all these organizations to really work in a very different way. A very simple example I will give you is one of our major partners is GE, and they produce this huge imaging machine that costs tens of millions of dollars. And one of the things we realized recently is that their ability to sell these machines to providers has been pegged on their ability to produce DVDs fast enough for the patients to take home with them. And you think someone in a hospital that's making a decision, a $10 million purchase decision, is asking this question of, can my patients get the CDs fast enough or the DVDs fast enough? So patients are going to drive the use case. They're going to say, here is the things we want to happen, and they're becoming more and more aware, and they're taking more and more control of their health. I believe 30 years ago, it used to be the case that the patient goes and assumes the doctor's going to do everything, they're going to take a pill and go home, and they're going to get better. And I think people's idea of healthcare is changing.
Back to the question again, where are the healthcare providers versus the consumers in understanding the HIPAA laws, security laws, and what they need to do to make us feel comfortable?
So I think that there's a huge heterogeneity among providers in their implementation of HIPAA and their compliance with it. I mean, that's an understatement of the century, right? But I don't think that consumers understand it, and I think that they think that almost every provider is compliant with the law, and that's the securest place for their data. I actually think that the general population believes that, even though we know it generally, that there's incredibly vigilant organizations who comply with HIPAA very well, and then there are completely negligent organizations as well. And so if they don't understand that there is this heterogeneity and that there are options and their security of their data is important, they don't drive, they don't make any kind of decisions on that data, right?
First of all, I never expected to hear that word when I woke up this morning.
Heterogeneity.
I did okay in my SATs, I thought.
I won't ask you to spell it, I promise.
Well, until 2009, doctors were actually disincentivized to adopt electronic medical records, and only the most affluent and most technologically savvy would, especially the specialties that are paid particularly well through their fee schedules or don't take private insurance at all, and it's, get paid for service. So you would see a high concentration of EMRs in Silicon Valley for one, in New York, and that was about it. 2009 came around, and with the stimulus bill, doctors that see Medicare patients can make $44,000 over 5 years, $65,000 if they see Medicaid patients. So there's actually it's balanced a little bit better. So there's not really a disincentive anymore. They're somewhat incentivized monetarily to adopt systems that can start to store their information, and those systems have to live up to a certain standard to help bring a bunch of EMRs up to a certain level of, everybody's kind of reasonably at the same level now in terms of functionality. But there's still disincentives in the market. Outside of Practice Fusion, any EMR company that charges the doctor, you're immediately disincentivizing them to use the system. And for the more complex systems, especially like Epic, it takes a week to even learn it. And so you have to take, can you imagine, that's in some doctors' offices, that's 150 patients that they haven't seen. That's 5% of their revenue potentially for an entire year. So physicians that were already, they make maybe 100, 120, 150 grand a year, but they're small and medium enterprise owners. They're having to put it back into their own business. Otherwise, they have to lay people off, and then they're in even a bigger bind because they can't, manage all the patients that are trying to come in. So those incentives had to be aligned a little bit better. Part of the reason that we're growing so fast is because we have removed almost all friction to get started. So we hope that incentives are aligned a little bit better, and doctors will take it seriously that not only will they be more efficient on a system that's easy to use and electronic, but their patients are going to be happier because they have access to the data online. They can, schedule their appointments online as well, so maybe you don't have to have that front office person doing what they're doing. They can focus on taking care of the patient when they're in the office. So I think incentives are starting to be aligned a little better, and it does start with the physician. The patients aren't going to know enough about their information to enter it in online. It's part of the reason Google Health didn't survive.
So I want to add one thing, and then you've also been waiting patiently over there. I appreciate it. And there's a gentleman with the microphone over here. Then we're going to probably jump ahead to one next question, unless there's anybody. I think I got everybody's been waiting at least for a while. So one thing I want to address in that question is that I think there's multiple levels, and so there's the knowledge part that you talked about, and I think that, I don't think over the last 5 years has anyone heard that word any word more than they've heard HIPAA, even when it wasn't appropriate. People have 2 A's and 1 A, and they don't 6 P's, and they just know they should say it, but they don't always know what it really means. But more than that, there's the implementation of that within the organization, right? So you can have a lot of knowledge about what you're supposed to do, what the legalities are, what the processes are, and then you walk in and find out they're running everything on Internet Explorer 4, right? And I say that because that happened to me before I left my last job at one of the biggest healthcare organizations in the world. And the nurse knew everything they were supposed to do process-wise. So the scope of that is systematic. So I don't know if that's something you can really break down to just, do these two people in the ecosystem understand what their role is? I think understanding is there. Implementation is hard. And implementation and responsibility is hard, and that's an organizational practice. There's organizations that are great at it, some that aren't. And I think that's kind of why I found it hard to answer that question at a micro level. At a macro level, I think that understanding is there, but the implementation of that understanding can much deeper. So there's a question here. This gentleman, you've been waiting for a while, and then the gentleman with the microphone.
Okay, I have no microphone. So I wanted to return to this notion of control of data.
Okay.
To me, control is responsibility. So who's responsible for the data? Well, there's been no mention that medical records are a legal document, and physicians are under incredible pressure to make sure that legal documentation is preserved and protected. So they are, in a sense, always responsible for any information that they get. So the idea that the patient is control, he may have control over a window into the data, a subset of the data, but he is never, in any sense, in control of the data. And then the other point I'd make is, I don't know that people outside this, the type of person who's in this room, really want to control the data. We've been talking about making healthcare more simple, less complex, and now if I've got to manage my own data, all of a sudden that's a lot more complicated for me to do. And a lot of people won't even be able to do that. So giving patients a window into their data is great, but control and responsibility.
Okay, so let me try to summarize that and kind of repeat that down for the group in the back. So, and I'm also kind of turning to a question that either people in the audience and the panel can do. Basically, I think the point was that whether the legality of an EMR documentation is a legal document, and the physician has certain responsibilities and rules in the process to manage that document. And then the question, kind of follow-up question to that was, is giving the patient management over their data actually making healthcare more complex? Because I would like to think everyone in this room is motivated by making it less complex and having positive outcomes. And so is the management or control, I want to make sure I use the same word, the control of that data making healthcare actually more complex? Is that fair? And then we can address that question?
Yeah, that's fair enough.
Right.
I think it's less about management of your record and more just about access and controlling who sees it. Except for maybe like the 0.0001% of the U.S. that are interested in the quantified self movement. Come on. Okay. All right. You miss it. I would love for it to be a high percent. Don't get me wrong. They don't really manage, the normal person doesn't really care too much, and if they really cared, they wouldn't be eating McDonald's every other meal.
Good question or follow-up to that? You seemed, in the scarf, you seemed ready to pounce on that question there.
Yeah, I've been an early patient as a privilege of caring for a child that had a
Can you speak up? I can barely hear you.
I'm an early patient.
Give her the mic.
So, my name is Karen Herzog, and I'm an early patient. I had the privilege of caring for a critically ill child with a rare disease, and I can't think of it being more important for patients to have access and caregivers to their records, because I have boxes and boxes of records that I collected, and thousands, tens of thousands of emails that I sent out over the course of 4.5 years. There was no easy system. So I would copy or send CNAs that I worked with. We made reams of copies to send to new doctors. And it was just absolutely ridiculous. It reduced the quality of my life. It reduced the time that I was able to spend with my daughter. And I just can't think of them. I mean, I worked with researchers and doctors all over the world. We did integrative medicine. We did quantified cells at home. I'm telling you, we all need access to our data. And we need to have control. We need to manage it. There was no doctor that was more interested in my daughter. They just weren't. It was my husband and I. And that's who needs access to the data. They need to control it. They need to distribute it liberally. I just can't say more about this. I mean, put yourselves in a position. Imagine if you're ill or one of your loved ones is ill. Who do you want controlling your data or your family's data? You or someone else? My doctor didn't care. I had worked with many of the most amazing doctors and researchers in the world, but you know what? They are dealing with a lot of patients and a lot of data and a lot of information, and they just didn't have the level of interest. So think about it in the reverse terms. When you're ill, do you really want that one doctor who may be on vacation in Tahiti and you need that doctor and your information? So anyway, I don't want to argue, guys, but I just want to voice the e-patient perspective here, and I think it's really critical.
So you've been waiting a long time. I'd like to let you ask your question.
Yeah, well, I think the key for what we see here is the option, right? To let the patient to have the option to decide what they want to do. Because as long as you say we don't, oh, it's not that critical. Some people think it's critical. Some people think it's not critical. And as I said, there is a different situation when you think one specific disease is, you don't want anyone to know, and some you don't care. So it's a lot about giving the option to the patient to decide what to do with his data. As you said, when you give them option, a lot of them decided, yeah, I don't mind. If you asked people 10 years ago, would you let people know what you ate last night at dinner? People said no, but everyone will put it in Facebook now because they have the option to do it, right? So it's a lot about options. As my ideal scenario would say, allow the patient to decide where to store the data. Not because right now you can maybe allow him to save the data through the medical record system through this specific provider. The ideal scenario from my point of view, and I don't know what you guys think about it, will be to put it in a place that he selects, to select the provider to put it with, so the person that he trusts. Now, it could be that he makes a stupid mistake, right, with someone that doesn't comply with HIPAA or whatever, I don't know, but his decision. So I want to know how do you see it? Is it something that's possible to get there in the future?
So to follow on to the question about credit card data earlier, basically what you're saying is, when the Nigerian doctors start asking for our data.
It's your decision. If you want to give them his data, it's your decision.
There you go.
Let people make mistakes. It's great.
Okay.
And it's not just a mistake. I think we underestimate the drive someone has to try to find solution for health problems when they have a serious health condition. You should. I encourage everyone to come to MedHelp, and I think it's. One thing I want to plug in very quickly is Google Health failed because they focus too much on the provider data and too little on the health user data. But if users have the ability to put the data in a place in a way that allows them to really learn from it and share it and learn more about their conditions through it, they are more than willing to do that. We have thousands of people who come every day to MedHelp to put their viral load information that they get from the lab about their Hep C and learn what affected it and what things helped it and didn't, what kind of medication other people are on, so that they can go back to their doctors and have real conversation over saying, I've seen someone do it differently, what do you think, right? So it's not about you treating yourself at home, but also about you being informed. And if you have a health condition, you have to be as informed as possible, and you want to learn from other people's data as much as possible so that you can have a meaningful conversation. So you're not just sitting back and being a recipient of the knowledge without really having any way to educate yourself and learn from your own data, from other data. And that applies to a lot of kinds of data. And one thing I would allude on the HIPAA side is that HIPAA's purpose is not protecting you from your data or owning your data or managing your data. HIPAA's purpose is preventing the data from being transferred to someone else without your consent as a user. That's really the main purpose of it. So if you think about that, if you go to